Around 80% of rare diseases are known to have a basis in people's genomes, either in inherited DNA or in de novo variants. That is when differences in DNA that owe nothing to the previous generation occur. And for this reason, genetic and genomic testing, ideally whole genome sequence analysis, can be crucial in establishing diagnoses and guiding treatment for those who are thought to have a rare disease. In the UK, these facts have been emphasised in official documents and government statements going back more than a decade now. The Rare Diseases Strategy of 2013 committed all four countries of the UK to making high quality diagnostic tests accessible. Then the Rare Diseases Framework of 2021 identified helping patients get a final diagnosis faster as the first of the UK's priorities for the next 5 years. Those 5 years have almost elapsed. Don't know where the time goes. So where do we stand now? Several services and resources seek to make rare disease genomic testing more accessible and useful. And these include NHS England's Genomic Medicine Service and the National Genomic Test Directory. Also, there's the Scottish Genomic Test Directories. Then there's guidance, such as the Association for Clinical and Genomic Sciences Best Practice Guidelines for Variant Classification in Rare Disease, and the British Society for Genetic Medicine's guidance managing incidental findings. All that's great, however, challenges do remain. Turnaround for times for various parts of the genomic testing process, patients' access to the relevant test, receipt of test results from an appropriate clinician in an appropriate fashion, and follow-up and referral where necessary are not always consistent and can take a long time. This can then extend what I'm sure we'll refer to a lot this evening. It can extend that diagnostic odyssey that's too often experienced by rare disease patients and their families. A working group spanning various professions and organisations published a position statement detailing these and other challenges and making recommendations to address them. And the authors who wrote this position statement also wrote about it, explaining it in a more summary form for BioNews, and you can find it there with the QR code. And on the panel, we have experts and advocates, including some of the authors of that position statement, who will explore rare disease genomic testing and discuss how we can make it equitable and timely. Let's introduce the first speaker, Dr. Sarah Wynn, who is Chief Executive of Unique, which is a wonderful charity which supports people affected by rare chromosome and gene disorders. She is one of the co-authors of the position statement on rare disease genomic testing in the UK and Ireland.
Sarah has given a really fantastic introduction to this event, which was really stimulated by the position statement that Sarah mentioned already. And this position statement outlined the best practice guidelines for the genomics workforce in the NHS. And the aim of that was really to think about how we can make genomic testing equitable and timely, which I think we can all agree is vital. Before we talk about that, I just wanted to go back a little bit to think a bit about what a rare disease is and why this access to genomic testing is so important for patients and families. So rare diseases individually are rare, but if we put them all together, they're collectively common. It's estimated about 1 in 17 people are affected by a rare disease in their lifetime. One of the figures quoted is there's over 7,000 rare diseases, and actually I think this is probably an underestimate. At Unique, where we are supporting families with rare chromosome and gene disorders, we've got about 1,000 conditions under our umbrella. So thinking about rare diseases, often there are no specialist care pathway or management guidelines because they're rare. There's often a lack of treatments. But despite this, getting a diagnosis of a rare genomic condition is really important to families. even where there is no treatment or specialist care pathway. And the reason is Sarah mentioned already that diagnostic odyssey, so bringing to an end that search for an answer, that looking for a diagnosis that many patients and families look for. We also know that patients and families are really looking for that answer. And so getting an explanation and a name for their child's at Unique, we tend to be a parent and carer support group. So we talk often about children, but also it's true for patients. So getting that name is really important. Once you've got a name and some information about your condition, we hope that stimulates research and data sharing, but also will hopefully lead to treatments further down the line. A really important part of what we do at Unique is bringing families together. So once you've got a diagnosis, you can find others and you can share your experiences and feel less alone and isolated. We also know that parents often feel a sense of guilt that their child hasn't developed as their siblings or as they might expect. And so getting a diagnosis can often relieve a bit of that parental self-blame and guilt. Also, families are often looking to expand their families and getting a genetic diagnosis, as Sarah said, and learning about whether it's something that's been inherited or de novo that's arisen anew in that child can help with reproductive decision making. So to jump back to that idea of the diagnostic odyssey that I think many of us will refer to during this evening, I often share this really sort of headache-inducing slide because it's a really good depiction of what many patients and families go through to get to that accurate final diagnosis at the end. Families, as you can imagine, find this incredibly stressful. Multiple tests, multiple appointments, asking multiple people the reason why their child hasn't developed as they expected is incredibly stressful for families. So anything we can do to reduce this diagnostic odyssey and reach that final diagnosis quicker and easier is a good thing. So we asked a number of our families at Unique what getting the diagnosis meant to them after they'd been living through this diagnostic odyssey. And often families talk about a sense of relief. They talk about things making sense once they get that diagnosis. I won't read out the quotes here because hopefully you can all read them, but that idea that it's answered questions, it's joined the dots. Families can then find other people, they can find support, and they can research and access clinical trials, perhaps, or research projects, or other families to share the experience of their rare condition. But even when it comes after families have been looking for the diagnosis, and it might come as an answer to all the questions they might have and be a sense of relief, there are lots of challenges in having a rare diagnosis in your family. The rarity often means there's a lack of information about how your child might be affected today and in the future. I mentioned before that there's a lack of treatments and care pathways for people with rare conditions. We know that often families struggle to get their rare condition recognised and get the right support and therapies in place because no one's heard of their rare condition. One other aspect of the rarity is that it creates a lot of uncertainty. What on earth does this diagnosis mean? We talk to families and it leaves them feeling confused and bewildered. Another thing that exacerbates this uncertainty is when the results themselves are uncertain. So when going through the diagnostic pathway, there are several categories of results that might come at the end of that genomic testing. Some of those are pathogenic and likely pathogenic, where we are relatively certain that genomic change is responsible for your or your child's features and symptoms. And then sometimes we find changes in the DNA that when we look more closely, we can see that they are just the changes that exist in the general population and are harmless. But there's a category in the middle called variants of uncertain significance. And this is where we can't be certain whether the change that's been found in yours or your child's DNA is a change that is responsible for those features. And as you can imagine, this uncertainty about whether this result is meaningful or not creates an additional set of challenges for families. Again, I've put some quotes here from some of our families and how they've experienced getting those uncertain results. And so I think also it's important to remember that genomics is not just about rare diseases. The 10-year health plan for England, which was published earlier this year, has a DNA double helix on the front, which shows you just how important genomics and DNA is. It mentions genomics over 100 times and predicts that 50% of healthcare interactions will be genomics in 10 years' time. So you can see that genomics is all around us, not just in rare diseases. However, when thinking about these big shifts that are outlined in the 10-year plan, there's three of them: hospital to community, analog to digital, and sickness to prevention. And while prevention is something that's really admirable and great to think about, we really also want to remember that we need to make sure that there are resources and that rare diseases are prioritized and care for the rare conditions that we are interested in are adequately provided for. So Sarah again mentioned this position statement here, which is published, as well as the comment that we published in PET, and she had a much more jazzy QR code than I've got here as a clickable link. But this came out of a one-day workshop that was convened by the Association of Clinical Genomic Scientists, and it brought together clinicians and clinical scientists, as well as patient groups. So both Unique and Genetic Alliance UK, which was mentioned earlier, were present at this one-day workshop. And the aim was to produce these guidelines that would facilitate equitable and consistent delivery of services for patients and families wherever they lived throughout the UK and Ireland. This position statement describes 8 fundamental requirements with a set of recommendations outlined here on this slide. The overarching objectives, as we've talked about already, is to facilitate high-quality diagnostic genomic testing delivered effectively and efficiently within a clinically relevant timeframe. Sarah also mentioned turnaround times earlier, and a key component of this guideline is about delivering genomic testing in that appropriate timeline and trying to reduce that diagnostic odyssey that we talked about. Implementing a service where the perspectives of patients and families, who are those accessing and navigating this testing pathways, is sought and included from service delivery right from the start. And again, as I mentioned, the one-day workshop right from the start included Unique and Genetic Alliance. And I think it's really important to remember that by including the patient voice, we will inform service delivery, an improvement that will maximise patient benefit. We also need to deliver effective and efficient service within a nationalised healthcare setting, and by making sure this is standardised across the UK so that everyone has equitable access and known access, so patients and families know what they can expect and the time frame in which they can expect it. Genetic Alliance, by the way, have a really brilliant guide which you can download from their website, which talks a lot about what makes a good diagnosis. And of course, it is getting an accurate and timely diagnosis, but that diagnosis needs to be framed in a number of different things. And so I really recommend you downloading that guide from their website if you want to know more about that. But I think the other thing we should remember is that through all of those patients going through genomic testing, around 50%, even with whole genome sequencing, are going to come out of the other end of genomic testing without a diagnosis. And I think what we need to remember is that the service needs to look after all of those that does get a result from genomic testing, but also not forgetting those that didn't get a diagnosis. However, by taking approaches where we can implement new technologies and perform reanalysis on existing sequences, we're really hopeful that that diagnostic yield will go up, and lots of those families that come out of genomic testing without a result, without a genetic result at that time, will get a result in the future. And so I think Emma's going to talk a little bit more about that later. But I am now going to pass on to Miranda who's going to talk a bit more about the laboratory side of things and how the genomic sequencing data is interpreted.
Miranda Durkie, who is head of rare disease at the Northeastern Yorkshire Genomic Laboratory Hub. And she is another of the co-authors of the position statement on rare disease genomic testing. Previously, she was lead scientist for rare disease at the Sheffield Diagnostic Genetics Service and co-author of the professional guidance Variant Classification in Rare Disease.
So I'm kind of talking from a laboratory perspective, and I wanted just to start with just a quick overview of kind of what happens in the lab. So this is an overview of kind of one of our most complex tests, the whole genome sequencing, and just to show you that the labs can be involved from kind of receiving that blood sample, sometimes through the sequencing, data interpretation, multidisciplinary team discussions, and generating that clinical report. But I really want to focus on this data interpretation step because it really can be quite complex and time consuming. So when we do a genomic analysis, we have to go from a very large number of variants. And when I say that, I mean in an average person, we would identify between 3 and 5 million variants. And we have to get that down to a much smaller number of variants that we can then do variant classification on. The process of kind of doing this filtering out the variants, if you kind of have good bioinformatics, then some of it can be automated, but still a lot is done quite manually by the clinical scientists. And if we are lucky, then we can identify those 1 or 2 causative variants that completely explain that patient's clinical features and gives that diagnosis for that patient and their family. So I'm just kind of highlighting this section because I'm going to come back to variant classification in a couple of slides' time. So Sarah gave us some really nice facts about rare diseases, and again, Sarah in her introduction talked about this diagnostic odyssey. And you can see I've highlighted here that one of the statistics is that it can take 5 years on average to diagnose a rare disease. There are multiple different reasons for this, which kind of we can go more into in the discussion if necessary. But unfortunately, there have been backlogs in the labs, as kind of been reported in the newspapers. So both of these were from 2023, which was when we convened that workshop for the ACGS position statement. And obviously that's leading to really long wait times for patients and adding to that diagnostic odyssey that we really don't want for patients. So I'm just going to hammer this point a little bit more. This is a paper that was published for a little bit older now, so 2022, and it's from a consortium of all the US and Canadian labs and best practice guidelines for whole genome sequencing. And in this paper, they said that it takes an average of 7.3 hours to analyse one WGS case, sometimes split across multiple highly trained staff members. And as such, this analysis represents the most time-consuming and costly step of WGS. So sometimes our jobs can really feel like this. We are looking for that needle in a haystack amongst a lot of variants. So we know that some data-driven quality improvement is required, and sometimes thinking outside the box and doing things a bit differently, as this seagull is here. So obviously it's our responsibility if we've got those backlogs and long turnaround times for patients who are waiting for their results. And we also need to ensure that we're delivering a high quality, timely service for all our patients, not spending kind of like a really, really long time on those few very complex ones that's causing others to wait longer. But we also have to balance that with, the worries about the scientists in the lab. What if we miss a diagnosis or make a mistake, and then what if we get sued? And these are, real concerns that I hear a lot. So a lot of those things were all discussed at the workshop that we held in 2023 and then published in 2024. And I'm really pleased to say that since that time, we have made significant improvements to the turnaround times. There is still a lot more work to do. We've been kind of busy upskilling some of our genetic technologists to do more of that analysis to free up more time from the scientists. We know that there are still some regional differences with turnaround times and backlogs, and obviously that leads to inequity, which is not what we want. And so there is definitely a lot more work to do in different areas. But I thought kind of for the rest of, purpose of this slides, I would focus on what has helped so far. So first, I'm going to go back to my variant classification, which was kind of my bread and butter and favourite topic. I think of doing a variant classification as a bit like doing a jigsaw puzzle. You have your variant of interest and you have to get evidence from all these different sources, put it all together and then weight it in order to come up with your classification. So you can imagine that getting all that evidence and then applying it can be really time consuming. In 2024, we published these ACGS best practice guidelines for variant classification in rare disease. And these set out really clear guidelines for how people can apply those evidence and where they get the evidence from. And as Sarah was saying, it means then we can kind of classify variants all the way from at the top where it's pathogenic in red, so very highly likely to be causative, all the way down to benign. Another really key thing about these guidelines is that we brought together multiple different guidelines so that these guidelines cover the classification and the reporting of all different variant types. And as well, Sarah was talking about in the her last talk about these variants of uncertain significance. So we provided lots of guidance on which ones to report and how to report them, because we know that they're very difficult for us in the labs, for the clinicians who are giving patients the results, and for the families that are receiving those uncertain results. So next on the list is proportionate variant analysis. And here we're really balancing, can we reduce down the number of variants that we're reviewing and reduce down that variant review time? And does that mean that we can report more cases in a clinically useful time frame? Well, the answer is yes. So the take-home message from that very kind of long word proportionate variant analysis is we don't need to do that full variant classification, that full jigsaw puzzle on every single variant. So one of the key messages is that if you find the likely cause of the patient's symptoms, then we can stop. So if there is a massive hole there, then we don't need to kind of keep looking for kind of other causes. Another big premise of it is that we can exclude variants that are very unlikely to be causative. So say you identify a variant in a gene and that gene has got a completely different range of clinical features that your patient has, then you don't need to kind of be going into detail looking at that variant. And this has really significantly reduced down the time taken for a whole genome sequencing test and other tests such as next generation sequencing. So from those, in some cases several hours down to certainly under an hour, sometimes under 30 minutes. So this has made a big difference. Another area is the gatekeeping by the clinical scientists to ensure that we're only testing eligible patients and ensuring that they have a really high clinical utility. So where the genetic testing is highly likely to change the patient's or the family's clinical management. Why? There are lots of reasons why. For the sake of time, I won't read these out, but you can read them. They are all very important. There is still work to do, I think, empowering the clinical scientists and also educating the clinicians in order to do this, because, some of the clinical scientists do still feel a bit uncomfortable saying no to doctors. And those are kind of typical quotes we get from scientists. Okay, next on my list is automation. And so we've seen that in the wet lab by having very kind of high throughput sequencer machines plus robotics that are helping us get that reduce down the time that the sequencing is getting through to analysis. Then this is quite regional, but we have implemented some AI-driven variant analysis in the form of decision support software in some areas of NHS England. So this is one of the decision support software called Imagine that we've implemented in the North East and Yorkshire. I'm also involved in a national project looking at a variety of these. There are a lot more other software out there, but this is really helping us reduce the time for analysis. And again, regional, but this is again another NEY in-house variant classification database. And just to give you kind of a few facts and figures, because I'm a scientist and I like those. So in the NEY, our implementation of Imagine has reduced down the number of variants that we're seeing that needs analysis as compared to our previous bioinformatics pipeline by 61%. So that really is saving us time. We can also kind of very quickly report those variants with those patients with no variants. And by implementing this classic variant database, we've now got more than 83,000 variant classifications that we're sharing across the whole of our region. That means if that same variant is seen in another lab in the region, they don't need to repeat that work and reclassify it. It's all the data is stored on here. And then I've highlighted those 15,188 variants that are complete, and we can actually import that into Imagine, which helps the AI filter and annotate the variants for the future. So I hope I've showed you a few things that we've been doing. We're really aware that there's lots more to do, so watch this space.
Now, following on from Miranda, we have Emma Baple, who is Professor of Genomic Medicine at the University of Exeter's Medical School, and she's another co-author of the position statement on rare disease genomic testing. She is the lead for genetics and genomics at the NIHR Exeter Biomedical Research Centre, and she is the medical director of the NHS Southwest Genomic Laboratory Hub. Emma is also co-author of the Professional Guidance Variant Classification in Rare Disease and Managing Incidental Findings, and a contributor to books, including Training in Pediatrics.
So I'm going to talk to you a little bit more about what comes next. Miranda's done what we need, what are our challenges at the moment, and how do we address those. But there's also lots and lots of exciting things happening in genomic medicine, and lots that the NHS is doing to bring those benefits to patients with rare conditions and their families. So just a really quick reminder that around 5% of the UK population will have a rare condition at some point during their lifetime, though the majority of those will affect children. We've talked a little bit about the UK rare disease framework, and we've now had 5 rare disease action plans in England that we're still waiting to hear if that will be continued. But the key overarching objectives of those were to help patients get a diagnosis faster, increase awareness of rare disease amongst healthcare professionals, better coordination of care, and improving access to specialist care treatments and drugs. It's still the case that despite all the advancements that we've had, less than 50% of people with a rare condition will receive a diagnosis with the current approaches that we use in genomics. And less than 5% of rare conditions have a curative treatment available. So there's huge amounts left to do. The key challenges for me in rare disease for us over the next few years are to obtain more diagnoses for those undiagnosed patients, to do that faster for everybody, to ensure that we are increasing the data available for clinical trials and engaging patients and families in clinical trials. And as has been mentioned a few times, really working towards that equity piece. So we've shown that the benefits of genomic medicine in rare disease have brought benefits to, we've clearly demonstrated those benefits of genomic medicine in rare disease, but we now need to create that equity and level up those benefits. And I'm going to talk predominantly about how we can do that within England in the NHS, using academic and industry partnerships, evidence-based approaches, and innovative strategies. So I'm going to talk next about how we harness the potential applications of new technologies, tools, and analytical approaches. And Miranda's talked a little bit already about the fantastic work that's going on to enable us to be better and faster at interpreting variants. And that's both standardization of guidelines and approaches, but also the exciting prospects that AI provides for us in that area. With the rare disease framework came luckily lots of investment from research organisations. So the Medical Research Council created rare disease nodes with specific areas of academic research going on for particular rare conditions, and LifeArc formed rare disease centres of excellence a short while ago. And Robert Taylor, who's one of the authors of the position statement, is one of the leads of a mitochondrial LifeArc centre, which I'm going to talk about a little bit more in a moment. But investment in research has been going on for rare conditions in the UK and in fact globally for many, many years. But we've all often struggled to bridge that gap between research discoveries, new technologies being developed in a research and used in a research setting incredibly effectively, but not managing to make it over into diagnostics, into clinical pathways. And the NIHR biomedical research centres and others do a tremendous job of looking at that, but also the NHS Genomic Medicine Service and NHS England Genomics Unit have really taken an interest in making sure that we are translating those benefits alongside investing in the Genomic Medicine Service as it is currently. And they created these 7 networks of excellence, one of which is the Rare and Inherited Disease Genomic Network of Excellence, which is led from the southwest in Exeter, but also with the colleagues in Manchester in the northwest and also in Newcastle and the northeastern Yorkshire region. And Miranda is involved in that, as are other authors of the position statement. So this is just showing a new technology which allows us to look at sequencing larger segments of the genome than we're able to do currently in clinical practice, and the work that needs to be done to make that possible to implement within a diagnostic setting. That involves things like practical infrastructure that's required, the ability to automate, the ability to do these things in a way that doesn't require lots of manual work. That's not implementable in an NHS service. And so lots of work going on to try to bridge that gap for this and many other things. We talked before about the fact that more than 50% of people don't get a diagnosis using our current testing approaches. And in England particularly, we have some of the most advanced genomic medicine services available to patients worldwide, and they are available to all patients who need them, despite the fact that we may not yet have got it right in terms of access for everybody at the same pace and speed. However, we are not making a diagnosis in about half of these individuals, and so there's still a huge amount of work to be done. And that involves looking at new approaches to using genome sequencing, but also bringing in multi-omics. So new approaches, looking at our proteins and looking at those in more detail, looking at our mitochondrial DNA, which are the cell's batteries, looking at that in more detail, looking at the way that our genes are made into the proteins that make us up, and measuring the impact of those sorts of things through technologies like RNA-seq. And we need to be able to do that to be able to increase that diagnostic yield and end that diagnostic odyssey. And so our next step is really looking at how we manage those undiagnosed patients who've already been through a lot of testing to date, but we've not yet managed to find the answers for them. I wanted to talk a little bit about a service that we offer for NHS England through the Exeter NHS Genomic Laboratory that came through those industry and academic and clinical partnerships in Exeter, with co-location of the laboratories with the university genomics groups and the NIHR BRC now, which really helps to catalyse bringing these new technologies through and new approaches through at speed. And that's not just done in Exeter, that's done across the country in other areas like Manchester, Newcastle as well. But it's a nice model for being able to translate rapidly these new approaches into diagnostics to benefit patients. So this is Ellie Rose, who is a little girl who was tested through the Exeter service. And she was born as a healthy, normal little girl, but developed around 6 months of age, lost developmental milestones and stopped being able to breathe. She ended up on intensive care and had a gamut of different types of investigations. And then eventually she ended up having rapid sequencing through the Exeter laboratory. And that identified a very rare condition, a very rare metabolic condition called methionine synthase deficiency that is a treatable and curative condition. Without that diagnosis, Ellie Rose would not have survived, but you can see her here on the right-hand side of your screen, having been treated without her tracheostomy and doing really well and developing as one might hope. So these rapid technologies can make a huge difference. And the way that this works is that we use genome sequencing, and we sequence the genetic material from both unaffected parents and the affected child. And we move from the 5 million variants we find in the human genome that Miranda was alluding to, using cutting-edge bioinformatics approaches and cloud processing of that data to get down to a more manageable number of variants for the clinical scientists to look at. We work very closely, the laboratory scientists work very closely with the clinical teams to discuss complex results, and they're able to obtain results for families in less than 10 days from the samples arriving to the result. And they can look at 22,000 genes in the human genome in a single test, looking for more than 6,000 rare conditions. The diagnostic yield for that is 43%, although it's up to 61% for certain presentations like epilepsy. But it's important to note that 90% of the referrals are parent-child trios, and not everybody has both parent samples available. So we need to be, when we cannot offer this same standard of test to children where one or both parents are not available. So there's an equity issue there. But with these new technologies that are coming on board, so this is an example of a new bioinformatics approach to genome sequencing that's been developed by Illumina that allows us to essentially almost replicate the approach we use in that trio sequencing, that parent-child trio sequencing, in an individual where we had neither parent samples available. So we can make a diagnosis, identify which of the parents a genetic variant has been identified for, and confirm that diagnosis in that child. And we need to be looking more and more at how we can do more things like that to increase that equity piece for where we aren't able to offer the same level or comprehensiveness of testing at the moment. What about reanalysis of genomic data? We need to get that balance between a person or family with a likely genetic rare condition who's not had any genetic testing yet, and a person or family where they've have a likely genetic rare condition, but they've had extensive testing and no diagnosis was found. We want to make diagnosis in those individuals, but we also want to be providing an equitable service. And the scientists need to be able to have sufficient resources and time to be able to balance both of those things. And we haven't yet got that right. We don't yet have that perfect balance. And we need to be looking at new and clever ways of automating our approach to reanalysis, because new disease genes, new genes linked with rare conditions, and new evidence for particular genetic variants, moving them from uncertain to causative, are being discovered every day. So we need to be able to capture that information and provide that back, but we need to be doing that in a way that is not so burdensome that we can't test those individuals who have not yet had genetic testing. And this is a really important example of this. So just over a year ago, this condition it's called Renew syndrome was discovered by some very clever scientists in Oxford, and working with colleagues across the country and worldwide. And they identified that this condition was actually responsible for about 0.5% of children with developmental problems. And that's really important. That's a huge discovery. We need to make sure those patients who have been tested historically are able to obtain that diagnosis, because we wouldn't have known about it at the time their test was done. And this is Lindsay and her little boy Lars, who were so delighted to get their diagnosis, which was actually made by Susie Walker from Genomics England, who did do work in the research environment that Ellen will tell you about, to go back and analyse all of the data that was in the research environment from patients who've been tested in England with a rare condition, and made many, many diagnoses. But I'll let Ellen tell you more about that. So just lastly, we also need to address those genomic healthcare inequalities in underrepresented populations. I've got a screenshot here that shows you that this is from the commonest database that the scientists use to interpret data. And we use that data from all sorts of different populations, but you will see there that the vast majority, 77% of data in that database, comes from individuals of European ancestry. We have very little data from individuals of Middle Eastern or South Asian ancestry and other parts of the world. And so we really need that data, because it helps us to interpret genomic variation in individuals who come from that background. Without it, we get these unclear genetic and genomic test results that Sarah was alluding to, and the chance that we miss a diagnosis or misdiagnose someone is increased. And there's a lot of work going on in Genomics England through their Diverse Data Initiative in partnership with the NHS and other organisations to address that. And also we need to be partnering and supporting other work that's going on worldwide to look at genome sequencing from population data sets where we know we don't have access to that currently. So in countries like Egypt, who have their own genome project looking to increase the amount of data available from their population, that will benefit people who are caring for people from that background all across the world.
So the next speaker this evening is Dr. Ellen Thomas, who is the Chief Medical Officer at Genomics England, leading on Genomics England's contributions to the NHS Genomic Medicine Service. She's an honorary consultant in clinical genetics at Guy's and St Thomas's NHS Foundation Trust, and she's a contributor to books including Rare Hereditary Cancers.
So I'm going to bring the perspective from Genomics England. We were founded in order to deliver the 100,000 Genomes project originally, and we now work in the genomics ecosystem. We offer diagnostic services to the NHS England Genomic Medicine Service. We look after the National Repository of Genomic Data, which is made available in a trusted research environment for research into healthcare purposes, and that is called the National Genomic Research Library. And we also carry out major research programs, including the Newborn Genomes program. So I'm just going to tell you a small number of things about each of those today. So our vision at Genomics England is a world where everyone benefits from genomic healthcare, and that is very much in line with the topic of today's discussion. And this is a slightly complicated version of what Miranda has already shown you this evening, which is about how we use whole genome sequencing as a diagnostic test in the NHS. And the early parts on the left-hand side there, you can see that this is a diagnostic service and that there is a diagnostic process which involves the NHS laboratories and clinicians requesting tests and extracting DNA samples. There's then a sequencing step, followed by the bioinformatics analysis pipeline, which happens in Genomics England systems, and then that absolutely crucial step where clinical scientists interact with the results of those tests then happens back in the NHS, as Miranda described, allowing the results to be returned to NHS patients. And NHS patients who are having this diagnostic test are offered the opportunity to donate their de-identified genomic and clinical data to the National Genomic Research Library, and that is where researchers can interact with that data and make new diagnoses. And I'll talk a little bit more about the process of returning those diagnoses in a minute. The NGRL at the moment only contains whole genome sequencing data from the diagnostic services in the UK, but we and the NHS in England are very keen to expand that and to be able to take in data for research purposes from exome tests or panel tests, so tests that are offered using different technologies, in order to try and really make sure that the value of genomic research can be extended to patients having tests which happen to be offered using different technologies. But at the moment, this is the system which has sort of demonstrated that this can work. This sort of feedback loop of information being shared for healthcare and research purposes. And one of our big goals in terms of thinking about how genomic medicine can benefit everyone is to think about how our expertise at Genomics England in compute and storage and bioinformatics can be combined with the expertise in the NHS to ensure that we are all able together to offer tests in the diagnostic context on the best infrastructure, using the best and most standardized and most efficient processes and systems. So that is something on which we are all working very closely together and thinking about where the different steps in diagnostic testing can most effectively happen in the next phase. So that's something that we all work on very much together. The diagnostic discovery pathway is that Emma referred to in her talk, is where new diagnoses are made in patients who have had a genomic test in the past, but at the time when they had that test, either as part of the 100,000 Genomes Project or within the Genomic Medicine Service, there perhaps wasn't enough information available about their condition. Perhaps that particular gene hadn't yet been discovered, and therefore they received a result that said that they didn't have a diagnosis identified at that time. But if we're able to go back later and find a diagnosis, we have a pathway where we are able to return those diagnoses, having gone through a set of checks, back to the NHS laboratories, who are then able to return those to clinicians and patients. So this tackles the issue that we've already heard about this evening, about it being tricky to balance the needs of patients who are having a test for the first time with the needs of patients who have had a test in the past. And it means that patients who have shared their data for research purposes can really rapidly benefit from developments in genomic medicine. And the Renew syndrome condition that Emma referred to was first came to light in around February 2024, and the diagnosis started being returned to the NHS in March and April 2024. So that's how quickly we're able to react in this ecosystem when we've got this well connected. And this is just a chart showing, you can't really see that what's on the axes here, but it goes from the beginning of 2022 at the left hand here through to September 2025 on the right hand side. And the top of that peak there for the number of diagnostic discovery results that have been returned has just gone over 5,000. Over 85% of the findings that have been reported so far have been reported back as by NHS clinical scientists as being of clinically relevant to the patient's condition. So this is a high yield process. And then finally, I'm just going to mention the Newborn Genomes Programme, and the study that we're running as part of this programme is the Generation Study. And we are recruiting 100,000 babies. We're about a quarter of the way to that target at the moment. And the study is really looking to evaluate the utility and feasibility of screening newborn babies for a larger number of childhood onset rare genetic conditions in the NHS using whole genome sequencing. So this study has been based on a huge amount of public dialogue and public consultation to make sure that we understood how the public and different groups within the public felt about the use of genomics in this very sensitive context. And in order to make sure that we were selecting the conditions equitably, we consulted broadly and professionals felt were the right ones to look for on the genome when we were in this context of screening healthy babies. So there were conditions and principles for screening which already existed, but in this case we have taken a bespoke approach based on that public dialogue in the context of a UK-based research programme, and that led to four principles. The first principle is that variants in a particular for selecting a gene for the programme is that variants in that gene cause the condition, and ideally that there's another test available in the NHS to demonstrate whether the baby definitely has the condition. As with all screening tests, all babies need further investigation after they have a result from the screening test. The second principle is that the condition is highly penetrant, so likely to be causing a condition in that baby and significantly impacts the baby's quality of life. The third principle is that early or pre-symptomatic intervention improves outcomes. And the final principle is that the intervention is equitably accessible to all. And that was based on a lot of expert NHS input. So these principles were really developed in order to make sure that we were being equitable in the way that we selected conditions for the programme. And the goal of the study is really to investigate a new route into diagnosis, so a route into diagnosis which would potentially, if the evidence shows that this works and that this is a good thing to do, then if and when it gets rolled out in the future as a screening program, it would be an equitably accessible screening program in the future, and that would allow a new route into diagnosis, which would happen, in very early childhood, and which, for the conditions that were selected, would really help to tackle that diagnostic odyssey, where the conditions meet the principles, if these principles are continued in future.
Our final speaker this evening, thank him for his patience waiting, is Adam Clatworthy, who is Vice Chair for Rare Conditions at the Genomic England Participant Panel. He is co-founder of CRELD1 Warriors, which is a charity which supports people affected by CRELD1 related diseases. And in his day job, he's an executive audience engagement lead for Google Cloud.
So, as well as being the vice chair for the participant panel at Genomics England, more importantly, I'm father to two very special children, Alfie and Lola, who are both diagnosed with a really rare condition called CRELD1, as well as father to Daisy, who is thankfully perfectly healthy. But I'm just going to share a few thoughts really from the patient perspective, and just sort of add to the discussion you've already seen here today. So, I'm not going to talk through everything on this slide, but I just want to shed some light really on the diagnostic odyssey that we had for our daughter Lola. All started from birth when she didn't really hit her milestones, but it was only really at 3 months when she started having seizures that we knew that something was really not right. So you can see here we had multiple tests over multiple months, in and out of hospital. The doctors had no idea what was going on. And it really took us a while before they even believed that she was having seizures. As many of you know, some of these seizures are very subtle at first. So it's a case of having to capture them on camera. So as you can imagine, really stressful, in and out of hospital. She tried 8 different anti-epilepsy drugs. None of them were really working. All through this, no support, no answers. When we first asked about genetic testing, the waiting list, we were told, was around 8 months on the NHS. So we actually paid to go private with the testing that we had for Lola. So she was first added to the epilepsy gene panel test. This is where they test for all the known genetic changes that could be causing her epilepsy. But this came back with nothing. She was then added to the 100,000 Genomes project, which we had no idea what was. There was no real kind of explanation as to what would happen next, what was the process. We obviously did some reading about what this program was, but we were kind of just added, and then we just waited for the results really. And while all this is going on, you're just in survival mode. You survive day by day. Obviously, we had all of the tests going on in the background as well. Like many parents that I've certainly spoken to, you become an FBI agent. You're just literally, you're reading everywhere. You're joining every different epilepsy group on Facebook. You're just trying to figure out what is going on with your child. One night, in pure desperation, Lola had a really bad day. I posted one of the videos of her seizures in one of the epilepsy groups on Facebook. And by pure chance, a mother in Canada connected with me, and she said, "Look, I very rarely go on Facebook, but I saw your video. It's exactly like the seizures that my son has, and also her daughter." And she said that they've been diagnosed with this condition called CRELD1. So I'm immediately going online looking for any information, but there was nothing in medical literature, certainly nothing connecting it with epilepsy. And we took this information to our geneticists in the UK, but we were kind of just brushed off. They just reminded us that there's nothing in medical literature. Why do you think it's this? And it was just a case of, we provided all the information. They were part of this rare study at Yale School of Medicine, and they were really just trying to get that first paper out there. So we were kind of, like I said, it wasn't treated with any significance. So we kept in contact with this mother, but we just figured it wasn't that. It was probably something else. So all while this is going on, we were making a tough decision about whether to have another child. So we spoke to many different consultants. We got as much kind of information as possible. But we were essentially told that Lola was a lightning bolt, that the chances of it happening again were pretty much, it was less than 2% was, I think, the figure that we were given. So fast forward a few months, we were blessed to welcome Alfie to the world. But devastating to us was that that joy was very short-lived. He started showing the same symptoms from birth that Lola had. And just 4 days after he was born, we sadly lost Lola in her sleep. And that was put down to SUDEP, which is a common kind of outcome for a lot of children that are undiagnosed. It was just, yeah, that was obviously devastating for us when you just welcomed a new child into the world, and then you've got this immediate alarm bells ringing about the condition. So again, we went back to the geneticists, stressing our belief that we thought it was CRELD1. We were finally listened to, but it kind of felt like we were only listened to because we'd lost Lola, and that was an immediate alarm bell. And I just want to kind of just mention a little bit around the moment of diagnosis for us. So after we went back to the geneticist with all the information we gathered, the other family in the US and Canada, we got a phone call out the blue, literally like 2 days later, saying that they had looked back into Lola's genome tests and they had found irregularities with CRELD1. And I remember that moment so vividly. I think we were just out in town and you get this call out the blue. You can imagine it floors you. They then said that they were going to test for Alfie. And again, within a few days, they came back to say that they had found the same CRELD1 irregularities. So as you can imagine, there was, we knew that how a lot of parents will go to geneticists with information that doesn't come to anything, but it felt like we were not really given a voice until this finding was found. So within that moment, we were kind of, okay, where do we go now? There's no information online. There's nothing in medical literature. The only community we had was a few families in this Facebook group in the US. We were the first family in the UK to be diagnosed with this condition. So as you can imagine, you're feeling very alone. You don't know where to turn. So where do we go? So this is where I just want to talk about how do we respond as a family to this loneliness. So our own experience of going through this odyssey with Lola and Alfie really showed us firsthand why the patient and participant perspectives must be at the heart of this work. Everything we're talking about today, while we are very much among the lucky ones that to have a diagnosis for Alfie and Lola, that clarity came through pure chance. That's not a system, that's a lottery. And I know we're talking about this a couple of years ago now, and things have evolved in a much better place. But there are so many other parents out there that are very much in limbo. They don't have a diagnosis. They don't have that clarity, and they don't have that hope that they're going to get that phone call, hopefully from the geneticist with some answers for them. So for me, that's why I joined the participant panel at Genomics England. It's really to help ensure that no other parents go through that same experience, ensuring that our collective voices as parents and participants are really heard and valued as early as possible. Progress in genomic medicine isn't just about the data or the technology, it's about people. Every genome has a face, every piece of data is a person and a family. And every genome in the National Genomic Research Library represents an individual who has made that decision to contribute to something bigger, often in the hope of helping others. Like, we have to be realistic that some of us may not get answers in our lifetime, but if we know that we're contributing to someone further down getting a result, that's really what inspires us. So the participant panel at Genomics England, it really exists to make sure that those individuals are not forgotten. They're not just the subjects of research, but they're active partners in shaping it. So our panel is made up of around 24 individuals that have all contributed their genetic data or their children's genetic data to that research library that's looked after by Genomics England. So what is our role? Like, we really hold a unique place in the governance of Genomics England. We sit on committees, we provide independent oversight and advice, and we really work closely with the leadership at Genomics England to make sure that we're actively influencing that decision making. And importantly, we're a critical friend. Like, we want to offer constructive challenge. We want to ensure that decisions about data, access, research are really reflecting the interests of the people that are behind the data. And we really want to make them understand the real world perspectives. Like, everyone going through this journey is going through a completely different journey, and we can offer that real world insight and making sure that, as some of the speakers today have spoken about, it's inclusive, it's ethical, and it's really effective. And one of the big things that we're doing on the panel is really looking at how we're improving experiences through effective communication. So it's not just saying thank you for contributing your data, but it's showing how that data is used. What are the discoveries it leads to? And then why does that matter? So throughout our own diagnostic odyssey, the lack of clear communication and support was just really frustrating, just not knowing what the process was, not knowing that there's this diagnostic discovery team that Dr. Ellen has just talked about, that's going back into the data constantly and looking at any new conditions that have emerged. Like, none of us know that that's going on unless it's clearly communicated. So it's not just by sharing our story as parents, but it's through my role on the panel that we're aiming to really bridge that gap between what Genomics England, the NHS are doing, and the families who are kind of navigating this journey. So most importantly, we're really committed to driving that clear communication of successes in an accessible language. It has to be free of medical jargon that can really frustrate and overwhelm families that aren't clear on how these things work. And one of the biggest challenges that we face is that Genomics England doesn't actually have direct contact with the participants of the 100,000 Genomes project. That vital communication is really managed through the NHS and through the regional GMSAs. So those are the Genomics Medicine Service Alliances that actually have that direct contact with the participants. So we've been really trying to help identify ways that we can reach these communities. How do we bridge that gap? So how do we work closely with them around sharing key updates? How do we create dedicated patient-friendly sections on the Genomics England website? And how do we signpost all of this really important information so that the families can find it more easily? So just finally, around how did we as a family and a community forge our path? So another focus for the panel is really about how do we provide clarity around that post-diagnosis pathway. So what Sarah was talking about earlier, you saw that squiggly line. We went through that in our own way. So how do we provide a bit more clarity for other families that have literally just had a diagnosis and they're feeling alone like we were? So when we got the diagnosis for Alfie and Lola, because nothing was known about CRELD1, we were essentially on our own. There was nothing published. So where did we go? So we created our CRELD1 community. So this is our way to connect with other families. Like I said, we were the first in the UK. We had to bridge that gap and form a community with all the other families in the US. At the time we got a diagnosis, there were probably about 15 families. Now we're up to about 35 families. We built a website so that we could share all of our key learnings with the world, so that as soon as someone got a diagnosis for CRELD1, it would come up top of the Google search rankings, because we know that's the first place that people go when they're trying to find information. We had to create our own scientific advisory group and build advocates to really help us provide that critical expertise about the gene and how it functions. We had to set up a patient registry so that the research community can use that when they're investigating the condition in more detail. We last year launched a UK charity for CRELD1 warriors. So this is how we can start fundraising, and how can we get access to grants to actually help us with that fundraising. We then had to find a researcher, so someone in a lab. We're working with a partner in the University of Birmingham who's generously giving up his time to actually gather skin fibroblasts of our children and actually build a cell model for CRELD1 and just get us on the first rung of the ladder as to what this condition is, how is it manifesting. And then I mentioned I joined the participant panel, and the reason for that was just to really help me better understand the ecosystem. How can I connect with others going through the same journey, and then find new connections as well? And just finally, I just want to say that we as parents were in a really privileged position. I'm totally aware of that. I work in communications, so a lot of the things that I've learned in my career, I've tried to apply it to this world. And my wife's a pediatric nurse, so she knew how to navigate the NHS, and she had contacts with certain clinicians. And we also had, thankfully, the financial means to go private for some of these things as well. But that's not the case for many other families. This isn't equitable or fair. So how do we really provide clear frameworks and guidance and really define what this pathway looks like for newly diagnosed families to really prevent them from feeling abandoned? So I shared my story about Lola and Alfie because it's the human reality behind every line of data. It's the journey that reminds us that our work isn't just about sequencing machines and algorithms and technology. It's really about how do we provide that hope? And it's about providing a system that really serves families when they need it most, whether it be faster diagnosis, clearer trial access, benefits from use of their personal data, or just simply guiding them or signposting them on a path forward for them. So our diagnosis didn't come soon enough for Lola, but it really could help us find a better future for Alfie. So that's why I wanted to share a few thoughts.
I think I'll go to Sarah Wynn first to answer this. From Alexis Taylor, who cares for those who have no results? So from your sort of patient support element, where do you see people going? Where do you advise them?
It's a really good question, Alexis, and hopefully going forward, there will be less of those families and patients coming through genomic testing that will be left without a result. But I think several of us have mentioned there still are around 50% of people that do have WGS and don't get a result. Here in the UK, we have a really fantastic patient organisation which is tailored exactly for those patients. It's called Syndromes Without a Name, or SWAN for short. And that organisation exists for all those people that almost certainly do have a genetic condition, but we just haven't been able to find what the genetic condition is. And so at Unique, we would signpost families to that organisation, which is actually run by Genetic Alliance UK. I don't know whether Emma Baple wants to come in and talk from a clinical point of view, what happens to those families in terms of care.
I can do. Thank you, Sarah. So essentially, it depends on what particular rare condition a person has. But I'm a clinical geneticist, and patients who have undiagnosed rare conditions who may have had genomic testing or different types of genetic testing would typically come under our care unless they fitted more under a specific clinical specialty that would be particularly relevant to their clinical presentation. But actually, we've been talking about this a lot more recently, because when I first started in our specialty, we made a diagnosis in far less individuals than we have talked about today. We had much less to offer people. And it is now becoming a good problem that we need to address, in that lots of the individuals and families that would come to Sarah or to others are now they have a diagnosis, but we don't necessarily have clear pathways for them to go to, but either a clinical diagnosis or a genomic diagnosis, because we hadn't been able to identify those causes of disease in the past. So essentially, it's a good problem to have, but it's a problem that we're working through nationally now. What is the best place for all these people to go? But if you have an undiagnosed rare condition, clinical genetics is often where you will end up. And there are always new things on the horizon for patients, and Genomics England and others are always looking at new ways that we might find those diagnoses, but lots of work to do there still.
Thanks. And I see that Sarah has put the website for Swan into the chat for people, so that's great. Adam, I don't know whether you wanted to come in on that one and share your experience, or whether you've got something to add.
I think it's just, like I say, just being really clear in the communication and just signposting as much as possible. And I see one of the questions is around, like, how would our experience have been different had I known all of this from the start? I think even if it's just like a blueprint for these are the things that you can do as a family to kind of create your own community, because we just kind of had to find this all out for ourselves, just through investing the time in speaking to many different specialists. And that's hard when you're a family that's kind of in survival mode. Like you're having to sort of find out who these individuals are that can help you on this journey, speaking to other families. And that's really where most of our insights and knowledge has come from, is just speaking to others that have been through that journey, and sort of just then kind of building up our own plan based on all that information.
Thanks, Adam. Okay, so I'm going to move on to a question now for Ellen. Two-parter. So, does that mean that patients who didn't contribute to the research database would be at a disadvantage as their data can't be reanalyzed? And then the second question is, what is the yield of their data analysis?
Yes, thank you. Excellent questions. So, in terms of the process for finding new diagnoses after the initial analysis has taken place, if there are some circumstances where somebody whose data is not in the National Genomic Research Library, so for example, somebody who didn't provide consent for their data to be in the National Genomic Research Library, there are some circumstances where we might still find a new diagnosis that might be, at Genomics England, or it might be in the NHS after somebody has had an initial result saying that nothing was found. And if that does happen, then we would definitely return those diagnoses. But it is definitely true that if families' data is present in the National Genomic Research Library, there will be many more people looking at that data. It will be included in many more analyses. It will be looked at by a much wider variety of researchers. So the chances of finding something new for a family whose data is in the National Genomic Research Library is definitely higher than for a family whose data is not included in the NGRL. In terms of the yield, it's the way that these kinds of analyses work best is instead of looking at instead of sort of looking at an individual family and starting with family 1 and then going back and having a look at family 2 and then going back and having a look at family 3 and so on, which has been a sort of traditional paradigm for how we might think about looking back for new findings. If you've got a large amount of information about a large number of families in the same place, then we've found that actually the way that you find most diagnoses most quickly is by actually looking at gene 1 and then gene 2 and then gene 3. So when you look at gene 1, you look across every family in the NGRL and say, is there anybody, if gene 1 is a newly discovered gene, is there anybody in the NGRL who has a diagnosis in gene 1? Let's find everybody at the same time. And if it's a very rare condition, we might only find 1 or 2 families in the NGRL who have that condition. But if it's a more common condition, so for example, with Renew syndrome, when we look back through the NGRL, we found 60 families all pretty much at the same time, who all had a diagnosis, whose child had a diagnosis of Renew syndrome, and those diagnoses were all able to be returned to the NHS. So the yield varies a lot. It's not something where you can just say there is a yield, as it were, but it's something where you can certainly, it's an very efficient way of taking new knowledge and using that knowledge for the benefit of patients as quickly as possible.
Great, thank you, Ellen. I don't think anyone else wants to come in on. Oh no, Emma, over to you.
I was just going to add that the data that is in the National Genomic Research Library relates to patients who've had whole genome sequencing, and there are many patients with rare conditions and families with rare conditions who don't have whole genome sequencing because that isn't necessarily the most appropriate test for them to have. But it does mean that there is less ability for that research to be undertaken because there isn't access for researchers to look at it, or indeed for the diagnostic discovery pathway that Ellen was talking about to be looked at. And it is an area that I know Ellen and Genomics England and NHS England are looking at, and it's a big priority area for us. But I wanted to make it clear that it isn't available, unfortunately, for everybody who has an undiagnosed rare condition at the moment.
Thanks, Emma. And while I've got you there, I've got a question for you. How long can the blood samples be kept so that those who tested as WGS negative could be retested?
So I guess that's a slightly two-part question, in that what we've just been talking about right now is how we might look at genomic data that already exists. And actually, that's probably, in general, our most powerful way of obtaining a diagnosis for people and family who are undiagnosed at the moment. We know that the work that Ellen just talked about around Renew syndrome, re-looking at that existing data, is really powerful. And similarly, the same scientist, Susie Walker's, worked with our team in Exeter and had found a diagnosis in children who were undiagnosed from our rapid genome sequencing service in a third of individuals who were undiagnosed initially. And the majority of that is things that might be more complicated to look at in an automated way, or new causes of disease that were not known about at the time that we did that additional analysis. So that data can be stored forever. And that is how long we store that is in general is still under debate nationally, because there is a huge cost to storing that amount of genomic data. But the potential power to provide answers to people for not just the problem they have now, but other problems that they might develop is really quite significant. Thinking about DNA itself, though, what we do is we don't keep blood samples. We take the genetic material called DNA out of those blood samples, and we can store that forever. And currently it is stored forever in the NHS laboratories, not everywhere else in the world, though, and not in private laboratories necessarily. But it isn't always that DNA that's stored is necessarily the best sample for us to be testing. So sometimes we would still need to go back and get other samples or fresh samples to be able to do those tests. But certainly there's been many tests that have been done on individuals from stored DNA samples that are many years old or even after they've died, because it's helpful for their relatives to do that.
Thanks, Emma. So the next question is from Caroline Field, who says that her son has a genetic chromosome de novo linked to Menke. I hate these rare diseases for the names. I know it drives me crackers. Henke. Hennecam, right, cut that bit out of the video, which have been told around 20 cases worldwide. And it's very unknown how things will develop for him. Is there anything people like me, for people like me to work with, an opportunity to work with professionals or testing to work together to find out more info and guide him with positive treatment in terms of development? NHS referrals seem not to be as helpful anymore, as it's so unknown. I get told I'm doing everything I can, which is understandable with the uncertainty. So I thought, Sarah, if you could start to answer that one, then, and Adam, perhaps give some words of wisdom from your experience.
Sure. I think this question covers a few things. And I think, Sarah, your issue with the name also highlights a real challenge of rare diseases, that they often have names that are difficult to pronounce and hard to remember. And that's not all that helpful for patients and families. So thank you for highlighting that as well. Caroline, we have about 10 families in Unique who have this condition, so you'd be very welcome to get in touch with us and you can join us. One of the things, and Adam's organisation does this as well, is connecting families with each other. You know, Adam's story is a really powerful one about how, his is extraordinary actually, that he got a diagnosis of CRELD1 from another parent, but that bit about parents being able to share their experiences and offer support and guidance is really important. So that peer-to-peer support, I think, can be really, really powerful for people affected by rare conditions. So you'd be very welcome to get in touch with us. I think the other thing to do is to, I think, perhaps Adam is better to answer this bit about connecting with other families and the hope that that can bring. Adam, I think I'm going to pass over to you now.
Yeah, sure. I can also add to the frustration around the names as well. So obviously our condition is around the CRELD1 gene mutation, but what often happens is when a first medical paper is published on a condition, they often name it after the scientists that discovered it. So we found out when our first paper was essentially putting CRELD1 on the map, that they've now changed the name to Gelans, which is the two surnames of the researchers that we were working with at Yale. So that adds another level of confusion. So everything on our website, we had to add Gelans just to make sure it shows up. And that's a confusion as well. But anyway, that's a side thing. I'd first like to say, look, if you want to reach out to me, I'd be more than happy to share our experience and help guide you. So please reach out. And I'm not sure where your other families or your community are based, but with us, the majority in the US. But I think that's where Facebook is amazing and that you can build those communities. So we have a dedicated page now where we share as much information as possible. And it's really about how do you combine all of those insights that you have that you can then share with the clinicians and the doctors. So we've been kind of gathering insights from posts on the Facebook page, information that they've shared with me in confidence. And I've just been writing a medical report essentially that any family can put in front of their clinicians with all of the learnings from all the lived experiences of what are the phenotypes, what are the symptoms that the children are displaying, in a way that those medical professionals will understand. And I think that's where AI is amazing in kind of helping you write it in that format. And it's really about just building a wealth of knowledge and understanding and putting it down on paper in a way that can then not just guide the other parents that are going through that experience, but also then translating it into the speak of the clinicians and helping inform them. Because often you'll be going to meet with doctors and clinicians and GPs. They'll be asking you, like, and that's what we still experience. They're asking us, like, what are you learning? Because so little is known about it. So I would just say it's really about gathering as much insight and how do you kind of inspire hope with the other families. I think it requires a few families to really just kind of take the lead, and it really depends where you're at on your journey. Like, some of them are in and out of hospital, they don't have the time or the headspace to be doing this, so you'll kind of get a feel for which of the families that have a bit more time to invest in this and really finding out who your advocates are. Hopefully that's helpful. Sarah, I see you might want to add to that as well.
I just wanted to add that at Unique, and Adam mentioned that Crowd Warriors have a registry, and we have a registry as well at Unique, and we collect all of that information from families. And what we can then do is, it helps inform us about these conditions, but we can share that information in an anonymized format to clinicians. So we can then help clinicians who are seeing patients with these conditions learn a bit more about what is known and what might not yet be in the published medical literature.
Great. Well, I hope you find that really helpful, Caroline. I hope it's from your other comment. It will help to start making you feel less alone. I'm going to move on now to a question for Miranda from Chris Burns, who says, the analysis of variants seems like a natural task for AI. Is there an effort to put this in place at least as a parallel path for comparison purposes? Chris then amended, sort of said, "Oh, you've now talked about it," but I still think I'd like to know a bit more about AI. Who doesn't at the moment? So if you could answer that, Miranda.
Yeah, certainly. No, it's a really good question because actually it allows me to kind of talk a little bit. So as Emma Baple kind of talked about, there's the Rare and Inherited Disease Network of Excellence, and I'm working for that. And kind of one of my projects is comparing these 8 kind of AI-driven and that softwares that are looking at that kind of large amounts of genomic data and trying to filter out lots of those variants and kind of produce a short list for the clinical scientists to look at. And all of them do some variant classification. So in that kind of scale that had pathogenic to benign, they're applying some of our kind of guidelines to give it to apply classification. They're very good at certain aspects of it, particularly the kind of computational aspects, but obviously it can be very, very hard. There's still some of the evidence that's a bit more subjective, particularly when it comes to kind of clinical features, etc. So the AI tends to find that much harder. But actually, we've got some big changes coming in variant classification, and there's an international consortium that are revising the variant classification guidelines, and we're expecting that new framework to come out next year. And they've tried to structure that in a way that's much more decision trees that will be much more kind of amenable to that machine learning. I think all of us that are involved in those guidelines as well, the new guidelines, feel like it's never going to be completely automatable. You are always going to need the kind of that clinical input and that scientific input, but it will hopefully help us filter out a lot of variants that we don't need to look at and just focus on those few and speed things up.
Thanks, Miranda. Emma, did you want to come in on this one as well?
I think essentially we're doing lots and lots of work, like Miranda said previously, around standardization and trying to make sure that everybody's doing things in a similar way. And we've made huge progress, haven't we, Miranda, in that area? And there's still a lot more work to do there, but actually the new contracts for the NHS Genomic Medicine Service will be renewed in April next year, and that will be part of those contracts will involve what we've learned around standardization and also around the things that have come out of that position statement. So we know that these things make a lot of difference when we're all doing things in the same way, and much more work needed to be done to work together on across as a network. That's one of the powers of the NHS, isn't it? That we're a network of people who are all wanting to do the best thing for patients, and we need to do more to harness that. But people were under a huge amount of pressure when these new genomic technologies came about. We'd moved in a very short period of time, from looking at a single gene and taking many weeks, sometimes months, to look at that single gene, to very rapidly sequencing the whole of a person's genome. And so doing that at scale was a huge challenge, and it has just taken a little bit of time also for people to catch up with that enormous change across the board, both from a patient perspective, a clinician perspective, and a clinical scientist perspective. But we are getting there, and lots of positive things that have happened as a result of that, and new learning that have come out of that.
Thanks. It's good to see what's coming down the track. It's always interesting to see how that's going to, come in, and then what the next thing will be after that, because these things are never static. So, the next question is from someone who's anonymous. They say there are big discrepancies in time to getting results back throughout the genomic medicine service. What's being done to try and even out this postcode lottery? I'll go to you first again on that one, Emma.
I suppose it kind of comes back to what I was just saying, really, which is all of those things. We're doing lots and lots of work to standardize and ensure that what we have learned from centres that perhaps have managed things in a way that's worked better, or resources that we know have worked, putting resources in particular places have worked better, and again, that standardization piece. But most importantly, I think we are, as I said, working more as a network now, as we sort of found our way through these early stages of providing a genomic medicine service, and going from being individual laboratories and research studies or organised by Genomics England. We've now moved to that stage where we're all working together much more as a network and applying that learning, and I think that's really reflected by the fact that there is much less discrepancy than there was even a year ago when we wrote that position statement, where there were really quite significant discrepancies. That's come down tremendously now, and most people coming into the genomic medicine service for a test wouldn't see those huge differences that existed a year ago, which is a testament to the sorts of work that was done in that position statement, but across the board by the laboratories and clinical services that are involved in the genomic medicine service, and people like Sarah and others who've helped us.
Anybody else want to come on that one before I move on? Okay, so looking at the question with the most upvotes, it's this one from someone who's anonymous. Why has there been so little discussion about which patients are presenting for testing in the first place, and which of these patients are being tested? Clinically, we're not seeing as many global majority patients for consideration of testing, and much more work needs to be done in understanding the reason why these patients are not being identified in the first place. And then of those who are, why are so few being tested? There is now clear evidence of unconscious bias and systemic racism, such as in the poor maternal mortality and morbidity statistics in the global majority women being treated in the NHS. And more scrutiny needs to be lent to this area too. So I think this was something touched on a little in terms of the big genetic data sets not being terribly representative unless you're white European. So I don't know who wants to tackle this one first. How is this going to improve? Perhaps I'll go to Emma first.
I'm going to ask if you might break that question down a little bit for me, because there were quite a number of parts, Sarah. Do you mind just breaking it down a little bit?
So I think really I think it boils down to why are so few people from the global majority not being tested and not coming forward. So perhaps it's why they're not coming forward and then when they're come forward, why they're not being tested?
I guess in terms of coming forward, I'd ask Sarah to come and comment as well in a moment. But essentially, there's lots of different reasons why people might not come forward for genomic testing. It may not be something that they feel for them is going to be of benefit. So, for example, when if parents have had a child with a developmental problem and that person is now much older, they may now not feel that they actually need that answer that they needed so badly when their child was very small. So that isn't an infrequent reason. But then there are also people for whom there is stigma attached to having genomic testing. So it may be that people have a feeling of guilt around genomic testing, both from a parent's perspective, or that people around that they feel people around them will judge them if their child is found to have a condition that may have been inherited in some way or from them. So I think there's lots of reasons like that. There's also a huge misunderstanding of genomics and a big piece of work for us to do there. What is genomic testing? What can be done with your genomic data? Is it going to be used to potentially catch you out if you've committed a crime in the future? If we test your child, are they going to be able to link you to something that you did or didn't do? Lots of different reasons why people might misunderstand. Will it be used by insurance companies? Will I not be able to do the things that I want to do? Will my child be restricted from doing what they want to do? So there's lots of different reasons why people might not come forward, and lots of work that we need to do that. There's also, Adam gave a really powerful story just now of the work that he had done to get a diagnosis for his children, but not everybody has the resources that Adam had at hand to be able to do that. Not everybody knows that they could access genomic testing, or that their child does look like they have features of a genetic condition, and they may not have presented to their family doctor, their GP. They may never have ended up in front of a pediatrician, and that again is more about getting that education out about what rare conditions are, and ensuring people with less resources or less things at hand to be able to help themselves or their child still have access to the things that they need. I don't know if anyone else wants to come in and say more to that.
Ellen?
Oh.
I think, Ellen, did you want to come in? Sorry, I thought you leapt forward, but if not, Sarah.
Yeah, well, I was just going to come in from the perspective of having a think about just mentioning about access to some of the big research programs that we're doing nationally as well, and sort of representation within those research programs. So it's something that we're very aware of in the Generation study, for example, that we are trying to generate evidence for how genomic newborn screening works for the UK population. And if we don't have a study which studies the UK population in all its rich diversity across socioeconomic axes and ancestry axes, then we won't be able to generate the evidence that allows us to, as a country, to decide what happens next. And so we are working very closely with our recruiting centres. We have many recruiting centres which serve populations who are very diverse, both ancestrally and socioeconomically, and that is deliberate in order to make sure that we provide the possibility of participation to as diverse a group of mums as possible. And we are working very closely with a number of groups who to really listen to how different people with different life experiences might hear offers to take part in genomic research. How can we provide information in a way which makes sense to people from different backgrounds, the role of people who are advocates in different communities, and working very closely with community advocates in communities who don't seem to be coming forward as readily really to take part in research. So I think it's not something that we've solved. It's something that's absolutely crucial, and it's something which involves a lot of listening and not making assumptions about how people might feel about what we're saying, about what we're doing, but really taking the time to, as much as possible, to explain and to listen.
And Sarah, did you want to come in as well?
Just quickly, because I think Emma and Ellen did a really good job of explaining things that are happening in both sort of access to services, but also research. But I think there are several initiatives that are trying to address this, and I think we know it's an issue both in terms of equity of underrepresented communities and ethnic minorities, but also that bit about parents who are, the parents who are able to self-advocate, as Adam did, and those that don't. And there's a real opportunity in the UK because we have an NHS and because the genomic medicine service is run is a centralised service in England. So, we should be able to tackle that inequity better. There's also an organisation called the NHS Race and Health Observatory, which is looking at identifying and addressing those health inequities in ethnic minorities. So there are lots of initiatives, but I think the question is a good one, and it's one that we should acknowledge is there and think really carefully about how we can address it. And I think the education of both and raising awareness of rare diseases and access to genomic testing is important in the general population, but also in all of those non-genetics healthcare professionals. So around making sure that GPs know when to access genomic testing or refer to clinical genetics and all of those other clinicians involved in care.
Yes, and it's something that PET has done an event on with Our Future Health, who are also trying to improve diversity in their data set. And they're doing a lot of work in that, not just in reaching out to ethnic minorities, but people who come from more socio economically deprived areas in the UK who don't often take part in this research. So there are things that are being done, and I think we all acknowledge there's a lot more that can be done to improve it. Okay, so I'm going to go on now to another question, which is sort of related, but it's from Jerry Ho, who says he wants to know how this could be used in developing countries where they lack the money to invest in such medical diagnosis services and equipment that we have in the UK. They don't have a genomics education, Genomics England project. They don't have Our Future Health. They don't have all these things that we have. Does anyone want to have a stab at that question? It's quite a tricky one. Not looking too keen. I'm going to to Ellen first because I feel like I'm putting a lot of pressure on Emma all the time. So I'll go to you, Ellen, and then I'll go to you, Emma, to follow up.
Yeah, I think it's a really, really good question. We talk quite regularly to researchers in other countries around the world who are looking at setting up global genomics initiatives. They are not equitably distributed across the sort of financial range of the financial firepower of different countries. That's definitely still the case. There are a large number of countries who have national genomics programs, but there are many others who don't. And so I think it's an excellent question. I think there are some fantastic initiatives. There's a fantastic H3 Africa initiative, which is bringing together genomics resources across the whole of Africa, doing amazing work. Obviously, the amount of ancestral diversity across the continent of Africa is absolutely enormous, and so having really strong initiatives across Africa is really important for us to understand more about the ancestry-based genomic architecture of populations. So I think there is great work happening, but it is definitely not equitable at this point. And we can only hope that with the ongoing reduction in prices that we're seeing for genomic technologies, the increase in numbers of genomic technologies coming onto the market, that will lead to pricing coming within the reach of an ever wider number of countries and initiatives.
I'm going to go back to you actually, Ellen, with another question from Amanda Jones, who says she'd like to join the Genomics England participants panel. She says, I work worldwide on inclusivity through networks. I have a rare disease, 3 in a million. How do I donate my genes? So perhaps I don't know, it's Adam or you that should be dealing with this first.
Well, perhaps I'll start and then pass on to Adam. So thank you very much for the question. So there are a number of routes to in the UK for sort of joining genomics programs. One of those is through the diagnostic program in the Genomic Medicine Service. One of those is through major initiatives during the point where those initiatives are open. So that was we had the 100,000 Genomes project. We've now got the Generation Study, and there are other sort of smaller scale programs. So we're doing some work at the moment with the NIHR Bioresource, sequencing patients with sickle cell disease, for example. So there are a number of different projects through which genomic data can be made available from people within the NGRL. All members of our participant panel have genomic data which is held within the NGRL. That is a very important principle. Members of the participant panel also, for example, sit on our Access Review Committee, where they provide advice to us about the sorts of research which are carried out on the data. So it's a very important principle that the people whose data is being used for the research provide that advice. So they are, as Adam has said, they are a crucial set of advisors and friends to Genomics England. We're very grateful for the time that they spend with us. So that's a few examples of routes into the system. But Adam, I should hand over to you on that one.
Yeah, I think it's fantastic to hear that you're keen to join. I'd just say reach out to me. I mean, we are recruiting for new panel members shortly because we have a number of members stepping down. So after 8 years, then we have panel members step down and then we go through a recruiting period. So we'd love to hear from you. So yeah, please reach out to me and happy to start that conversation.
Great, that sounds good. Might save you a few pounds on recruitment. You never know. Philandra Costello has asked a number of interesting questions, and I think she's given me the perfect question to sort of round up for this evening, which is for all the speakers, what does success look like in 5 years' time with regards to equity, access, and diversity in genomics? So let's go to Adam first. We'll go in reverse speaker order, and then I'll probably forget halfway through what order you spoke in, but we'll go with Adam first.
Sure, and I don't know how many of you on this call saw that story about 4-week-old Freddie. It was on the BBC News a couple of days ago, and I think that really kind of paves the future that we would love to see. So for those of you who haven't read it, have a look. Basically, he was part of the Generation Study, so newborn as part of his local hospital. They actually found out that he had a rare form of eye cancer that would not have been picked up until later in his life, but they immediately found it as being part of the Generation Study where his genome was sequenced. So they've now been able to identify a treatment to address that. And you cannot underestimate the importance of treating these conditions early. So I think that for me is the future that we'd love to see, that parents, as soon as they're bringing children into the world, they're given the option, would you like to donate your child's DNA to the Generation Study? And I think give that example for every parent as you're recruiting them and saying, look, this is what could potentially, you could save your child's life for a condition that they don't even know that they may have until like years down the line when it's too late. And I just think in terms of the equity, it's really about making sure that we are educating our nurses and those at the point of contact with patients. The NHS is incredible. The nurses are incredible. We've had amazing service, but it's how do we make sure that they are armed with the knowledge to have these conversations with those who are in hospital and at least educating parents as to what genomic medicine could do to benefit them. And it's just starting that conversation, because without that, you have nowhere to turn. So I think that for me, like that's paving the way for the future we'd like to see, where everyone can benefit from genomic medicine that could potentially save their child's life or another child's life just simply by giving up your genome data.
Helen.
Yes, thank you. It's a very, very good question. So probably raise two things. The first of which is that I hope that the public dialogue that we're able to have about genomics over the next 5 years will continue to grow in depth and in nuance and in reach, to really understand more about how different members of our community feel about their genomic data and how it's used, and make sure that we are able to use it to its best purposes for everyone, so that everyone can benefit from genomic medicine while trusting the system with their genomic data. And I think the second one is really around reference data sets and having better access to data sets which are to the variant the patterns of variation across different ancestries globally, and that we're able to come together better globally to give all of us that improved diagnostic precision. So those would be the two things I'd love to see in the next 5 years.
Okay, we're rapidly running out of time. Emma.
Well, I can save you. I'll be quick because Ellen just took my one, so I'm going to be really quick because that was my top one as well. I'll make sure everybody has the same ability to obtain a diagnosis. But I also think for me, it will be having that undiagnosed patient pathway set up really well. So we have an automated reanalysis process. So everybody's data is reanalyzed where they don't have a diagnosis, and we're able to define who will most benefit from testing outside of genomic testing. So all our new omic technologies, functional genomic tests that are coming on board, that we've got good pathways to ensure everybody who needs them is able to benefit from. So those are mine.
Miranda?
Well, I agree with all of those. I have two more to add. So one is I talked about our regional variant database, and we really need something nationally so that the tests that go on that are not whole genome sequencing, we have that repository that we can share that data. And another piece of work that we're starting to be able to do in the labs, but it's very dependent on kind of good IT systems, is to look who is referring cases to us and actually look by patient postcode, and then we can see if there's kind of areas that we are getting a much lower referral rate, and then we can kind of target the education of those clinicians. And it's absolutely everybody in the health service needs that kind of education in genomics, and that will improve that equity of access.
Brilliant. And Sarah, have they covered everything?
They've covered everything. I quickly was going to go with data sharing and education.